Hello and welcome to TiCME, Time Critical Medical Education. My name's Dr. Nick Taylor and I'm an emergency physician based at the Canberra Hospital. Today's TiCME Plus tutorial is about difficult ventilation problems in the emergency department. Part 1 today is about ventilating severe asthma. Before we start, please see the basic ventilation video first for an overview of ventilation physiology. Alright, so let's start with a case. A 23-year-old man with a history of asthma is brought to your ED by ambulance. They state he is extremely short of breath, has a normal blood pressure. He was initially semi-conscious but seems to have got a little bit better after getting some oxygen and a bolus of fluid. He arrives in your department and someone does an ECG, and during this he develops severe respiratory distress. On auscultation, all you can hear is a soft, high-pitched expiratory wheeze, and he doesn't seem to be moving much air. You treat him maximally for asthma, so you give him IV hydrocortisone, continuous nebulized salbutamol, followed by an IV salbutamol bolus, and then IV magnesium. But despite all this, he's continuing to deteriorate, and you decide that you need to intubate him. So you've made the decision to intubate the patient. So let's have a little think about what are the genuine indications. In the past, people have often said that if someone's CO2 is normal or rising, then the patient needs to be intubated. I think what you'll learn today is that softer indications such as this are probably not the reason to intubate an asthma patient, because putting a tube in just opens up a whole new series of problems. So genuine clinical indications for intubation are cardiac arrest, respiratory arrest or severe bradypnea, physical exhaustion, or mental state change which is interfering with delivering treatment or oxygen delivery. Now, you sometimes have to look at some of the lab components as well to make a decision. So laboratory indications must be combined with the clinical state. And they would be profound hypoxemia, particularly if it's interfering with mental state, severe acidosis, which is not improving, and a very high CO2. And remember that this is a relative indication for intubation, and a lot of the time, once you ventilate your patient, the CO2 will be higher than when you started. So first things first, how are we going to safely intubate this patient? We have to think first about the potential pitfalls involved. And once we put the tube in, we need to know how to set up our ventilator. So what are the problems that we need to think about when we're going to intubate a severe asthmatic? Well, first of all, the patient is usually awake, so we have to put them off to sleep. They are usually profoundly hypoxic and they have absolutely no reserve. Asthmatic patients are particularly difficult to ventilate using positive pressure ventilation. Asthma patients get problems with preload because they have very high intrathoracic pressures, and this limits venous return, and that's called dynamic hyperinflation. We'll talk more later about dynamic hyperinflation. Asthma patients have a significant risk due to the high pressures of barotrauma, and asthma patients often develop mucus plugging and significant atelectasis. As with any intubation, you need to have a plan before you start. You also need to have a backup plan, and you need to rehearse these with your team prior to starting. You need to continue to provide maximal bronchodilator therapy throughout. It's really important you don't stop everything just because you're planning to tube the patient. My suggestion is, if you have the ability to use non-invasive ventilation, that you put the patient on that before you start to try and maximise your opportunities for pre-oxygenation. I think you should keep the patient sitting up until you're about to give the induction drug. The other thing you can do is put high flow nasal prongs oxygen on and leave that going throughout your intubation attempt. you should always set up your self-inflating bag with a CO2 monitor first and make sure it's calibrated and working. And you can consider getting a better ventilator down from theatres or your HDU or intensive care unit before you're commencing. If you've got a very basic transport ventilator, you will find it will struggle when ventilating an asthma patient. So, what are the options to consider when you're going to intubate your asthma patient? Well, first, we could try it awake. We could think about giving a sedation but not a full RSI. Or, if it's possible, we could transfer our patient to the operating theatre for a gas induction. So let's talk about each of these options in turn. What about an awake intubation? A lot of people think, well, this would be ideal because I don't have to stop my patient breathing, and it's a lot better than stopping them breathing and paralysing them. Now, this would possibly be an ideal method if it was genuinely possible by emergency staff. But remember, we've got a critically unwell patient here. It's not something we practice, it's very difficult, and it's very unfamiliar for all the staff. Remember that traditional laryngoscopes do not easily allow an awake look. You've got to put a lot of force on the soft tissues of the pharynx to try and get a view, and this is very difficult for an awake patient to tolerate. So sedation and relaxation may actually be an integral part of the process in getting a successful view. It may be that modern video laryngoscopes such as AirTrack or GlideScope or many of the others can allow a view of the cords with far less discomfort and in less than ideal patient positions. But again, you'd want to be fairly well practiced at this before you try it on the most unwell patient you'll see all year. Nasotracheal options are one of the more traditional ways to achieve an awake intubation. Asthmatic patients often have nasal polyps, which makes this almost impossible, and it's really not advised in inexperienced hands. Some people advise using lignocaine to try and reduce bronchospasm. Certainly the effect is minimal, and intravenous lignocaine has no effect really. So option 2 is what's called a facilitated intubation. Instead of a genuinely awake intubation, you use some sedation to try and make it easier. The patient, however, remains breathing. Ketamine would probably be the ideal drug in this situation. You might use something like a less than full induction dose, like 0.5 to 1 milligram per kilogram intravenously. You could use a traditional or video laryngoscope. And some people would advise giving a muscle relaxant once you get a view to obtain passage of the tube through the cords. What about option number 3? Well, that's a full rapid sequence induction, and you would use a rapid acting muscle relaxant. Ketamine may again be the drug of choice for this because of its bronchodilator properties, and you would use up to 2 milligrams per kilogram IV. Although it's always important to use a drug with which you're familiar, and that will genuinely be better. RSI has the advantage for most people of being a familiar condition in which to intubate and will provide the best intubating conditions. Its disadvantage is if you have problems with the intubation and the ventilation, you can rapidly get into unremitting badness. Sucks as the muscle relaxant is probably still the relaxant of choice due to its very short duration of action. There is some potential of bronchospasm from histamine release, but this is probably clinically irrelevant. Recent studies experimentally have shown that rocuronium may provide a longer safe apneic time, however, because it doesn't cause fasciculations which chew up oxygen. And what option is option 4? Well, that would be the transfer to an operating theatre for a gas induction and intubation. It has multiple potential advantages, such as the gas providing bronchodilator properties, a more experienced intubator doing the intubation, and the most important, it's SEP, or somebody else's problem then. You should strongly consider this option if it's available in a non-crashing patient who may be able to be transported safely. The reality is, however, of an after-hours transfer to an available OT with experienced available staff may make this option impossible. So what are some of the caveats when you're deciding how to intubate your patient? Well, first of all, the most important factor is you need to get the tube right the first time. And for ED intubations, the result of the NEAR studies confirm the superiority of RSI over facilitated intubation. The success rate was much higher for first attempt with RSI versus sedation only. For paediatric patients, it was even higher. This was a huge study, multi-centre, of more than 6,000 ETT attempts. What about induction drug choice? Well, ketamine doesn't affect the brain's CO2 responsiveness. It allows central ventilation to continue, and it is a bronchodilator. It does increase the blood pressure, and it may keep airway reflexes intact. Propofol also has some bronchodilator properties, but it is also a potent negative inotrope and a vasodilator, so you need to make sure your patients are preloaded with fluid before you start. Opioids probably aren't the drug of choice because they do cause histamine release, which can worsen bronchospasm. So in this situation, you go with what you're familiar with and you decide on a ketamine and SUX RSI. Thankfully, everything goes amazingly smoothly. The tube is in and it's confirmed by the end-tidal CO2 trace. What now? Unfortunately, with severe asthma, the problems only just begin once you put the tube in. There is very high airway resistance and intrathoracic pressures. There's very high autopeep, barotrauma is an ever-present risk, and mucus plugs make ventilation challenging. As we mentioned before, dynamic hyperinflation occurs where breath stacking happens. The intrathoracic pressure rises and preload reduces to the point where it can lead to cardiac arrest. So what are the principles of ventilation in severe asthma? You need to reduce hyperinflation and reduce autopeep where possible. Autopeep occurs where low expiratory flow causes incomplete emptying of the alveoli. You can imagine once this gets critically high, the alveoli become increasingly large with every breath. As the end expiratory lung volume increases, so does the end inspiratory volume for a given tidal volume, and this causes lung hyperinflation. What ventilator mode should we pick? Well, pressure control would usually be the best initial choice. It allows you to set a safe cut-off limit for pressure to prevent barotrauma, and it also gives you a good idea of what the pressures are inside the patient's chest. There is some recent evidence, however, that a volume mode may have some advantages. Remember that spontaneous modes, such as the CPAP pressure support setting, do not allow the capacity for you to control tachypnea, so initially they're really not recommended. So let's talk about some of the ventilation strategies to use in severe asthma. Firstly, we want to reduce the respiratory rate, and we need to reduce it down to at least 6 to 10 per minute, sometimes even lower. Now, this will allow time in expiration, and it has the greatest effect to reduce hyperinflation. It may cause hypercapnia, but in asthma patients, mostly you're just going to have to wear this. We can also reduce tidal volume, and we should be aiming for around 6 to 8 mils per kilogram. Most patients, especially when they're being handbags, are overventilated at 10 to 12 or even greater mils per kilogram. Remember that dead space will proportionally increase as you reduce the tidal volume, and this may actually limit the amount of tidal volume reduction you can perform. Next, we need to increase the IE or inspiratory-expiratory ratio on our ventilator. This is particularly useful if we can't reduce the respiratory rate enough due to hypercarbia. Now, the normal IE ratio is about 1:1.5 or 1:2. In severe asthma, we need to start about 1:3, 1:4, and sometimes go even longer. This allows time in expiration, which is critical to try and reduce gas trapping. We need to set an inspiratory flow rate of at least 60 litres per minute and a square inspiratory waveform. This will shorten the inspiratory time. What else do we need to do in asthma? Well, we need to not focus on trying to bring the CO2 down. And this strategy is called permissive hypercapnia. Roughly, we should aim to have the pH above about 7.15 and the CO2 less than 80. There are some times where this is just not possible. We should avoid significant hypercapnia though if the patient already has a significant anoxic brain injury, because as we know, high CO2s cause cerebral vasodilatation, and severe acidosis will cause myocardial depression. We don't want to add PEEP to most asthma patients because they have a huge amount of auto PEEP. Now, sometimes if they're spontaneously breathing, a low PEEP of 5 or so may reduce work. If you have a very sophisticated ventilator and you can measure the patient's auto PEEP, you can actually add PEEP up to a critical amount which may reduce work of breathing. Auto PEEP can be monitored, and it's really an ICU style thing, but I mention it because it will estimate the lowest average alveolar pressure, and you can do it by measuring a breath hold at the end of expiration. You should aim for it to be less than 15 centimeters of water. You can also monitor a pressure called the plateau pressure. Again, you can do it at the end of inspiration with a ventilatory pause. A lot of ventilators can do this, and it measures the average end inspiratory alveolar pressure, and you should aim to have the plateau pressure less than 30 centimeters of water. We need to make sure the patient is heavily sedated so they can tolerate the ventilation. So often we'll use a combination of ketamine with things like midazolam or propofol. Remember that ketamine is beneficial in some respects because it has an additive bronchodilator effect. You should avoid paralysing your patient once you've got control of their ventilation, because it causes a myopathy which can inhibit weaning. I would suggest that you do keep your patient paralysed post-induction, because it's often very difficult to establish the patient on the ventilator, and what you don't want is them fighting the ventilator. So certainly in the emergency department, I would advocate keeping your patient paralysed. In the intensive care unit, they can then take the paralysis away and rely on sedation and their more advanced ventilator. So let's get back to our case. 5 minutes after his grade 1 intubation and establishment on the ventilator, he drops his saturation suddenly to 70% and his blood pressure falls to 95. What should you do now? So first of all, to decide what to do, we need to know what are the causes of hypoxia or hypotension to consider in the patient who's being ventilated with severe asthma. Well, unfortunately there's a long list. The two most important are pneumothorax and dynamic hyperinflation, but also patients can get severe bronchospasm, lobar collapse. You might have tubed them into their right main stem bronchus and are actually just blowing up one lung. They can obstruct their tube with all the mucus they're producing, and sometimes it could be drug effects, such as the propofol you've used to keep them asleep. So our patient has suddenly dropped their sats and blood pressure. What should we do? Get someone to arrange an urgent chest x-ray if possible. Take the patient off the ventilator and begin to handbag them very slowly. Listen to their chest. Immediately reduce the respiratory rate, and I would suggest at least halving it, or if they're pre-arrest, trial 30 seconds of apnea. Now this is to try and treat dynamic hyperinflation to allow time for expiration to occur. Make sure you look to make sure you haven't done a right main stem bronchus intubation or a pneumothorax. Give the patient a significant fluid bolus, such as 500 ml stat. Immediately treat for pneumothorax if there's unequivocal clinical signs, or you've got some evidence. And ultrasound's a terrific modality to use for diagnosis in this sort of situation, but you'll also see it on chest x-ray. And consider that the patient might have some other causes here. Remember, they're under a lot of physiological stress. Their sickness may have been brought on by pneumonia, which has caused sepsis, or they might have had a heart attack. Okay, so if the worst comes to the worst and the patient has a cardiac arrest, The most likely causes are dynamic hyperinflation or tension pneumothorax. You should immediately trial apnea ventilation for 30 seconds to a minute whilst you commenced CPR. Now CPR has the additive effect of emptying the lungs, which may be dynamically hyperinflated, and sometimes you will get spontaneous return of circulation immediately. You should also consider a needle thoracostomy, particularly if the patient has not had circulation return within a minute. Remember that the side to try can be very difficult in a silent chest, so an ultrasound again can be very helpful. This is the chest X-ray of the patient that we've been following the progress of. Now, as you can see, there has been almost complete collapse of the right lung caused by a huge pneumothorax. Luckily, at this point, there isn't sign of tensioning, but the patient is severely unwell. You immediately decompress him with a 16 gauge cannula and then insert an intercostal catheter. The blood pressure and sats improve out of sight. Now, you've got your end-tidal CO2 tracing and you're on the monitor. Remember from the ventilation talk that this end-tidal CO2 tracing is showing very steep alpine style ventilation due to severe bronchospasm. The other thing that you'll notice is in all the excitement, someone is handbagging the patient far too quickly. Remember that the end-tidal CO2 is going to be high in asthma, so I wouldn't necessarily get concerned that it's around 60 to 70 at the moment. So after his initial stabilisation following the ICC insertion, he again drops his sats, so you get another chest X-ray. What does this one show? Well, you can see that your ICC is in the right place. The lung seems to have reinflated, at least in the upper lobe and the middle lobe, but then you've got this very dark wedge-shaped opacity in the bottom of the lung adjacent to the diaphragm. So this is essentially his right lower lobe, which has collapsed. So, lobar collapse in asthma is often due to mucus plugging. You can ventilate the patient with collapsed side up by putting pillows underneath one side of them. It's really important to use a humidified circuit and keep regularly suctioning the trachea. In extreme cases, bronchoscopy can be considered, and in this patient they eventually had a bronchoscope which removed a very thick mucus plug from their right lower lobe bronchus. At this point in the ED stay, it's time to get the patient out, and whether that is by activating medical retrieval unit or moving the patient on to your intensive care unit, the better ventilators and the one-on-one nursing is really important at this stage. So today I hope you've learned that it's very important in severe asthma to have strong indications for when you're going to intubate the patient, to recognise all of the serious pitfalls and problems involved in intubating and ventilating a patient, and also to have learnt the basic principles of ventilating an asthma patient and some of the complications that can occur and the management of these. Thank you very much for listening, and I'll see you next time on TiCME.